Bismillahirrahmanirrahim. My name is Dr. Ambarashad and today my topic of presentation is typhoid, also known as enteric fever, under supervision of Professor Dr. Saira Afzal. In this presentation, I shall be giving the brief introduction to typhoid with case presentation, epidemiological factors, change of transmission, clinical manifestations, and antimicrobial resistance, and the magnitude of this problem with levels of prevention and recent advances. At the end of the presentation, the participants will be able to describe the epidemiological aspects of typhoid, preventive aspects of typhoid with national global updates and recent advances. So this was a recently reported case of Black African male healthcare worker that was admitted on 21st July 2022 with significant chief complaints of headache, loss of appetite, and watery diarrhea. He traveled a few days back, and this case was reported in Pakistan. The admitted patient presented with 2-day history of hyperthermia, headache, loss of appetite with watery diarrhea, as well as back pain, joint weakness, and insomnia. The H antigen titer was positive, which was 1.189 greater than the normal range, and showed the past history of S type infection. The O antigen titer value detected was a false negative result because it was done before the 7 days onset of fever. So the differentials that the doctors made were typhoid fever, malaria, hepatitis A, and dengue fever. But on admission, ciprofloxacin 500 mg was given orally twice a day for 7 days to treat typhoid by inhibiting the deoxyribonucleic acid replication. Hence, the typhoid fever pathogenesis was based, in this case, the typhoid fever pathogenesis was based on pathogenic factor, infection species, and host immunity. And agglutinin biochemical test, Budol test, was able to identify the patient's bloodstream as carrying the S. typhi bacteria that caused the typhoid fever. So during his travel, due to the contaminated food and unsafe drinking water sources, typhoid fever is associated with travel to developing nations. So vaccination is of prime importance, and vaccination of adults should also be considered before traveling and also in normal routines to control this multi-drug and extensively drug-resistant typhoid strains. So the symptoms are typically either it's constipation, diarrhea, mostly it's diarrhea with headache, nausea, vomiting, abdominal pain with relative bradycardia, rash of flat rose-colored spots, and high-grade continuous fever. So, as I have already told, that it is due to Salmonella species and paratyphi A, B, and C. WHO has estimated a high burden of the disease in the previous years and has also been considered endemic in Asia, Africa, and Latin America, including Bangladesh, China, Nepal, Pakistan, and Vietnam. This is an area map showing the higher prevalences of typhoid in Pakistan, including Pakistan. So typhoid incidence overall, the overall populations per 100,000 year, more than 100,000 per year population is reported in Pakistan. Recently, a report on by NIH Islamabad showed that there were 14,000 cases of extremely drug-resistant typhoid fever in Karachi. And this was from 2016 to 2021. And actually, it was 2019 when Pakistan became the first country in the world to introduce this typhoid conjugate vaccine. And this was now because of these reported cases, and now it has been included in the EPI schedule. So, multi-drug resistance typhoid has been reported, and it is against the 3 antibiotics: the ampicillin, the trimethoxazole, and chloramphenicol. And extremely drug resistance is resistant to 5 antibiotics, including the 3rd generation cephalosporins and fluoroquinolones. And during COVID days, because of this poor sanitation and other restrictive services, typhoid cases have been reported in large number. And when and when there was a research that this use of erythromycin was used for COVID-19, then it was also being practiced against these typhoid cases as well. So agent I've already told about, and the factors which influence the onset is completely dependent on the infective dose and virulence of the organism. So it is a bacteria, it's a gram-negative bacteria, and it is a facultative anaerobe, and human is the only host for this uh, agent. So for the host factors, all ages are susceptible, but highest incidence is among 5 to 19 years of age, younger age group, school going age group, gender, mostly males and females, immunity, all ages are susceptible to infection. And among the host factors that contribute to resistance to S. typhi are gastric acids and local intestinal immunity. So enteric fevers are usually reported in this current season now. This is the coming season for typhoid fever. Typhoid bacilli do not multiply in water, and many of them perishes, but they can persist in the human host for a very long time, and there are also carriers for this state that can stay in the body for several years. So 10 to 14 days is the incubation period. And 5 Fs, always remember the 5 Fs because it is totally and having an orofacial route of transmission. So 5 Fs like flies, fingers, feces, food, and fornication. So I've already told that there are several sources of infection. It can be a fecal oral route or a urine of a cases or a carriers can be a source of primary infections. And secondary sources, as I've already told, are related to food and other items and hygiene as well. So reservoirs, man is the only reservoir, and the infection can present in terms of cases, active and the chronic and the carriers. There are different types of carriers present for this disease. So whenever coming to the case definitions, so probable or a suspected case is such a case in which there is fever and prior to the presentation to the clinic, or clinically compatible, that is epidemiologically linked to the confirmed case, having fever only and no other focus to explain the fever. But a confirmed case is having a typhi culture on blood or bone marrow, and a chronic carrier is a such who's having S. typhi in stool and urine longer than 1 year. So such a patient is considered as a having chronic carrier. So there are two types, temporary that are incubatory and convalescent and chronic carriers. So chronic carriers can be presumptive and definitive carriers. Presumptives are shedding for an unknown duration, but if the duration is known and is more than 12 months after finishing an appropriate course of antimicrobial treatment, that's a definitive chronic carrier. Or you have two positive stool samples 12 months apart. So convalescent carrier sheds bacilli for 3 or more months after the onset of acute illness, and salmonella is positive on stool culture for such patients as well. So coming to the antimicrobial resistance, this is a phenomenon of interest nowadays, and it has caused lots and lots of problems throughout the globe. And many institutes or the nations are collaborating to control this upcoming antimicrobial resistance flood. And for this, this is the resistance that refers to intrinsic and extrinsic factors which makes microbes resistant to antimicrobial treatments like medicines, and which may threaten the human health and human and animal health as well. So there are three types: non-resistant, that is uh, sensitive to first-line drugs, and third-generation cephalosporins. For multi-drug is such a case that is resistant to this first-line recommended drug of treatment, with or without resistance to the second-line drugs, that first-line drugs and third-generation cephalosporins. But the extensive drug resistance is such a strain that is resistant to almost all the antibiotics recommended, first-line and second-line drugs. This was a study that was conducted in 2021 showing that the whole process that started in 2019, and it took a great increase into 2021, with almost all the provinces that are being involved in, and many cases were reported, like in KPK and Punjab and Sindh. And when the study was conducted, the result showed that every area of Pakistan was affected and the cases of XDR were being reported. So this problem is huge, considering the scenario for Pakistan. And this extensive drug resistance is a big problem, because most of the commonly used antibiotics in the routine, the strain is highly resistant, including these third generation cephalosporins that were considered quite effective against the the other strains. So this was the timeline. Sorry. And it all started from 1960, when the first MDR's epidemics were reported, but not in Pakistan. And it all went through 1970s, 80s, and coming to 90s. There were fluoroquine resistance outbreaks, and in early 2000s, there was ceftriaxone were superior to fluoroquinolones, and 90% of South Asian strains became resistant to fluoroquinolones. And in 2016, there is a ceftriaxone resistant outbreak was reported. Then sporadic reports of azithromycin resistance were also reported in 2018. But in 2019, reports of intercontinental transmission of XDR typhoid cases from Pakistan to US, UK, and Canada were reported. And these cases, for these cases, azithromycin, glycines, and carbapenems became the last antibiotics used to treat this XDR typhoid. So coming to the prevention, as we know that primary prevention is health promotion and specific protection. So health promotion includes hygiene promotion, improvement of water, better sanitation, and ensuring adequate and timely access to patient care. So according to WHO, vaccines have been recommended. 3 types of vaccines have been recommended. But the latestly is the typhoid conjugate vaccine that is also being used in Pakistan and is currently quite effective against the resistant strains as well. So there is TY21A vaccine that is orally administered. And protection immunity is achieved in 7 days after the last dose. And storage temperature is like any other vaccine of +2. The unconjugated vaccine has lesser efficacy than the conjugated one, but it was used in the previous years, and it is a single dose vaccine, and is a licensed vaccine, and is given through an injection and gives protection, but boosters are recommended for every 3 years. But the typhoid conjugate vaccine has been considered a miracle in this era, and this has very good results till now. And it is a conjugated vaccine with tetanus toxoid, and in an intramuscular dose of 0.5 ml with children greater than 6 months of age, and in adults up to 45 years is recommended. So in Pakistan, we have all 3 the currently available vaccines is TY21A, single dose injectable, and a single dose typhoid conjugate vaccine that is being used since 2019 in Pakistan. So none vaccine is effective 100%. So vaccinating everybody includes all household members whenever there is a confirmed case. Healthcare workers and also the food handlers must also be vaccinated against this particular disease. So secondary prevention is early diagnosis and prompt treatment. So for clinical features, as we know that for the first week there is malaise headache, second week it's mild hepatosplenomegaly with relative bradycardia, third week there is a typhoid state with diarrhea, and if left untreated can cause death, and rare complications are also present. but mostly the patient becomes chronic carriers when the bacteria goes to the gallbladder. Diagnostic techniques: blood culture is the gold standard, and blood cultures can be taken even if the patient is currently afebrile. And negative culture does not exclude typhoid and may warrant a repeat culture if the fever is not responding with 7 to 9 days. And other serological tests are Vidal and Typhidot that are not recommended for typhoid because of the low sensitivity and specificity of the tests. So the treatment of typhoid since the emergence of this extensively drug resistance has changed and it has become a challenge. So fluoroquinolone resistance, it was previously prescribed, but the fluoroquinolone resistant cases started appearing after 2016 and 17. So they were relatively expensive, but nowadays meropenem and other carbapenems are the drug of choice for such cases. So first line drugs are chloramphenicol, triamcinolone, and ampicillin and amoxicillin. Second line antibiotics is ceftriaxone, cefixime, and ciprofloxacin. While the third is azithromycin, meropenem, imipenems, and these drugs are nowadays being used for XDR. So for the carriers, there is an intensive course of ampicillin, amoxicillin, high doses, and probenicids for 6 weeks. 6 weeks, and carriers should be kept under surveillance and should also keep in mind their hygiene levels. So this has been discussed already, but getting to the treatments, the non-resistant typhoid easily responds to the first line and the third generation cephalosporins. For the multi-drug resistance, the second line drugs are preferred, and as I've already told that for the extensively drug resistance, stronger antibiotics like carbapenems, meropenem is sorry, are recommended. So there is a time for research advances. So there was a report of drug resistance typhoid recently, and the recent emergence of a new superbug that is the extensively drug resistance suggests that current antimicrobials may not be able to successfully treat this typhoid much longer. Since the game was to multi-drug resistance, it was still treatable, but after the emergence of this extensive drug resistance typhoid, uh, uh, vaccination was considered very, very important, and the results were very good when it was first introduced in 2019, and it was seen that the vaccine, typhoid conjugate vaccine, was found 97% effective against XDR typhoid in an outbreak setting. So if treatment treatment through antimicrobials is not being very effective, so go for the vaccination or mass vaccination campaigns. And to help to accelerate the development of new and improved antibiotics to tackle this drug resistance, WHO and the Drug of Neglected Diseases Initiation established a non-profit research and development organization, that is the Global Antibiotic Research and Development Partnership, with more than 50 public-private sector partners in 20 countries to develop and deliver 5 new antibiotic therapies by 2025. Although they are not necessarily intended to combat drug-resistant typhoid, other diseases are also targeted for that. But one of the diseases that is targeted is the drug-resistant typhoid. So this was another paper that was recently published, showing that ceftriaxone-resistant salmonella infections paratyphy identified in the case of enteric fever, first case reports from Pakistan, year 2023. And this was seen that the ceftriaxone resistant strains of S. para A was seen, and this is a significance as ceftriaxone is commonly used to treat paratyphoid fevers, and resistance in S. para is not known. So continuous epidemiological surveillance is required to monitor the transmission and spread of this antimicrobial resistance among typhoid salmonella, and this will guide the treatment options and preventive measures, because this was not previously seen with paratyphoid A strains. So next is the potential role of vaccine in preventing antimicrobial resistance. So this was recently published, and this report shows that the novel therapeutic and prophylactic strategies to fight AMR is urgently needed, and in this scenario, vaccine constitute a promising approach and is crucial in preventing the pathogen spread in primary infection and minimizing the use of antibiotics. So the new generation vaccine, which exploits novel strategies such as reverse vaccinologies, bioconjugates, and new adjuvants, may represent a key factor for successful production of potential vaccines, and synergic approaches involving research of new antibiotics and improvement of vaccine production is required to counteract efficiently this AMR occurrence. And next is this travel associated XDR typhoid cases in non-endemic regions. So XDR fever is particularly risk for travelers to Pakistan, and empiric use of carbapenem and azithromycin should be considered. Pre-travel typhoid vaccination and counseling are necessary, and urgent intervention, especially for visiting friends and relatives and travelers, is important. An ongoing sentinel service of XDR typhoid is needed to understand the changing epidemiology. So this was for the recent updates. Now it's time for the MCQs. So a massive typhoid vaccination campaign underwent in 2019 using which type of vaccine in children that were early targeted from 9 months to 15 years. Which type of vaccine was used based on this outbreak in 2016-17, and this campaign was started in 2019. Any idea?
Alpha.
It was typhoid conjugate vaccine, as I've already told, and during that year, the excellent results of these typhoid conjugate vaccines compelled our policymakers and other higher officials to add this in our normal routine, and now it's given at a particular time in the EPI schedule as well, close to 15 months, 9 and 15 months. Research has highlighted the overuse of erythromycin to treat COVID-19, and the practice might impair one of the few remaining solutions against which type of drug resistance: multi-drug resistance, extensive drug resistance, methicillin, penicillin, or ampicillin drug resistance. Any other idea? Any idea? It's very easy. It's extensive drug resistance, because extensive use of these drugs might cause problems for treating such cases of XDR in Pakistan. Worldwide drug resistance against typhoid is quite difficult to treat. What do you understand by the term extensively drug resistance typhoid? STIV is sensitive to first line. STIV is resistant to first line, with or without second line, resistant to 5 classes of antibiotics. STIV resistant to all types of antibiotics except 3, and STIV resistant to third generation cephalosporins only. Any idea? It's C, resistant to 5 classes of antibiotics. There are multiple case definitions which describe the carrier state, which laboratory tests confirm the chronic carrier state of typhoid fever. Blood culture, stool culture, urine culture, withdrawal test, PCR test. Any idea? It's B, stool culture. Because for the chronic carriers, they commonly, during an active infection, the patient might shed the S. typhi in their urine through the urinary part. But in case of a chronic carrier state, the stool cultures are mostly preferred for the laboratory confirmation of such cases. So B is the right answer. According to the recent guidelines, blood culture is gold standard for diagnosis. Why withdrawal test is no more recommended? Any idea? Its low sensitivity and specificity, that is the main reason why withdrawal test has been obsolete and is not being used currently as a diagnostic test. So blood culture is considered as the diagnostic test for typhoid fever. An unsanitary borehole latrine with lots and lots of flies is present within 10 feet of the well. The disease more likely to be transmitted through drinking of the water of the well would be, in this case, leishmaniasis, schistosomiasis, dental caries, typhoid, watercomb.
C.
Yes, it's typhoid fever, as it's relevant to the context of the presentation. Drug of choice of treatment of chronic carrier state in typhoid fever is drug of choice, chronic carrier state. Either it's neomycin, levofloxacin, ampicillin, propanicids, clindamycins, or erythromycins. It is important because chronic carrier state is very important in case of it's very common in case of typhoid fever, and mostly we do not know that what is the reason behind this chronic carrier state. Either it's discontinuation or incompliance or mistreatments or XDRs. So the drug of choice is ampicillin and propanicids in case of chronic carrier states when the case is established as having the bacteria in the stool culture for more than 12 months or 1 year. There are multiple signs and symptoms of typhoid fever which presented by patients in OPD and emergency. From these symptoms, relative bradycardia and nose spots are most likely to be seen in which week? First week, second, third, fourth, and fifth week. The rod spots and the bradycardia, relative bradycardia. It's second week of infection, and after that it's start third week with that is marked by profuse diarrhea, and if left untreated it may cause death, and after that later on if it continues and it causes complications. After 13 hours of eating at a wedding, 15% report abrupt onset of chills, fever, nausea, vomiting, profuse watery diarrhea. The most likely organisms responsible for these food poisonings would be any idea? Salmonella, Clostridium perfringens, Streptococcus.
Alpha.
Yes, referring to the context, but if it comes generally not in context with typhoid fever, you always look for the time. If it is more than 24 hours or 48 hours, then C and D could be the options, but as it is 13 hours, less than 24 hours, so the most appropriate uh, 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 option to choose here is Salmonella. Otherwise, you can consider C and D as well based on the time that is given in the scenario. And there are multiple vaccines, and one is live attenuated vaccines. And what is the recommended temperature for this live attenuated vaccine? Any idea? Like any other live attenuated vaccine, what should be the temperature of storage for such a vaccine generally?
E.
SB +2 to +8 degrees centigrade. That is for most of the live attenuated vaccines recommended temperature, and it's in the refrigerator compartment of the ice-lined freezers. Sorry, it's either in the middle compartment, I guess, or in the refrigerator portion of the refrigerator. So here is the key. Here's the YouTube link, and thank you so much.
Thank you so much, Dr. Amber. Allah Hafiz.
Allah Hafiz.